And thanks, Dylan, for the 5 minutes.
Cool. No, it's a pleasure. All right, guys, just while I set up here, I just wanted to welcome you all to this week's TUT, where we're going to be looking at some practical district hospital level orthopedics. And yeah, I just wanted to welcome Prof. Gibson, who is my dad, who's offered some of his time to go through 2 topics with us today. So we're trying to make this as relevant and specific to the kinds of things that you will see as a doctor working in a district hospital. And Colles fractures and Weber ankle fractures are definitely some of the more common types of fractures that you are likely to encounter. So we're going to spend about 30 minutes on each of those. And if you do have any questions, Norrie will create opportunities to ask questions every so often. You're also welcome to post questions in the chat, and then I'll create a space for you to ask questions. Let's just see, Norrie, Dad, are you there? I think he just needs to unmute himself. Cool.
Okay.
All right, there we go. Over to you.
Okay, Dylan. Shall we move on one slide, I think?
Yeah.
Okay. Right. Well, hello, everyone. I'm Norrie Gibson. My career has been at Frere, which is, I suppose, a tertiary hospital now, but I think I have a heart for rural medicine and have spent a couple of years doing it myself. So hopefully what I say is helpful. Be very, very happy for anyone. I mean, I like interactive talking, and I know with the audience being bigger, that's more difficult. But if there's anything that you'd like to ask question-wise, then enter the chat group, and Dylan will forward that to me, and we'll get going. Okay, so we're going to talk, first of all, the first half is going to be on Colles fractures. Dylan, next slide. So, right, so distal radius fractures are the most, if you combine all distal radius fractures, it's the most common orthopedic injury. And the FOOSH stands for fall on an outstretched hand. So obviously when you fall over, and we all fall from time to time, then we put our hand out to stop us from injuring our vital structures. So FOOSH, fall on an outstretched hand, is a mechanism of injury. Strictly speaking, Colles fracture is a fragility fracture, which means that it's one of the fractures that people get when they get a bit older, together with vertebral fractures, spinal fractures, hip fractures. Those are the types of fractures people get when they're postmenopausal ladies and elderly men who haven't got hormonal support for their skeleton. Okay, having said that, we include, and most people now include, when they talk about a Colles fracture, they're just saying it's a distal radius fracture. So there's therefore high energy as well as low energy fractures. So the Colles fracture in the fragility is more the low energy fracture, but there are those people who present with distal radius fractures who are younger, and that's because there's more force involved in the injury pattern. Okay, from a gender ratio, 2.3 to 1 females to males, that really is in line with the fragility fracture situation. Let's put there that a risk factor of osteoporosis, because this could be the index fracture. So a person who is osteoporotic and they're presenting with a minor injury like a Colles fracture, which can be easily managed by you or me or anybody else in many instances, but it's the index fracture of their osteoporosis. The types of investigations we can do to confirm osteoporosis would include doing a DEXA scan and doing a quantitative CT. Basically, that's not available to you in the district, but if you've got access to go online, then you can do a FRAC score, F-R-A-C, a FRAC score, which is an online assessment as to what the risk is of the patient being osteoporotic. And if that is the case, then patently supplementation with medication would be the way to try and go. Okay, so let's just get that out of the way. Intra-articular, 50% of these fractures do enter the wrist joint, and one of the orthopedic principles would be if there's intra-articular involvement, then the fixation needs to be rigid with early active movement, as opposed to metaphyseal, in other words, extra-articular, where we're trying to maintain length and alignment is the critical thing. So 50% of them being intra-articular, I think you need to look out for that. And then, in addition to the Colles fracture, there may well be associated injuries, and those would include what we call the drudge, or the distal radial ulnar joint, or involvement of the radial styloid, the TFCC, that's the triangular fibrocartilage complex, and carpal ligaments. And then people could present, it's more common with the high energy, but it could present with a carpal tunnel syndrome related to median nerve injury. So the X-ray just really shows a simple extra-articular distal radius fracture with some dorsal tilt. Okay, let's move on. Okay, from a prognosis, how do these injuries do? Just a few markers with regards to who does well and who does not. So you look at the successful outcomes on the right. The more accurate your reduction and the maintenance of your reduction, the better the outcome, and the early restoration of function. So your OTs, physios are critical to getting good outcomes, and one doesn't want to one doesn't want to keep these injuries immobilized any longer than necessary. So, the rule of thumb in orthopedics is 6 weeks. So 6 weeks in a cast, then mobilization. But even within the cast, function of the fingers is an elevation of the arm is something to be working on. So early restoration of function is critical to successful outcome. Poor outcomes, I think we all know this: workman's compensation, low socioeconomic status, educational status, and as we've mentioned already, low bone density. Okay, so those are just a few things to think into. You aren't really in control of the poor prognostic ones, but with regards to the accuracy of reduction and the early restoration of function, one can do something about that. Okay, next slide. Okay, how do they present? We all heard about the dinner fork deformity. As you can see, my dinner fork and somebody's distal forearm. So the history of a fall on outstretched hand, fouche, present with pain, swelling, and deformity. There can be bruising and the deformity, as you see. So that's probably what you're going to see. That's obviously quite gross, but it could be a little bit more subtle than that, but that's what it is. Okay. Next. Okay, so I think this is a request for you in the places where you work to try and get as good a quality of X-rays pre-reduction as possible, because the treatment is best decided on by the pre-reduction X-ray, and that's what you're going to get before you refer the patient, if you refer the patient. So try and get good quality X-rays when you start off. And we're really looking at, obviously, AP and lateral. It's 2 views 90 degrees apart, focusing on the wrist joint, and one needs to make some form of assessment as to how it's displaced, whether there's either volar or dorsal comminution, and whether it enters the joint or not. So those would be the factors that would determine how we're going to manage this. Next one. Dylan, you asked me not to focus too much on classifications, but I'm not mentioning this for you to remember it so much as to explain it. Okay, so effectively, if you look at the top row, this would be a fracture slightly more proximal to the distal radial ulnar joint, and it either does or doesn't involve the ulnar styloid, and it either is or isn't intra-articular. And the row of drawings at the bottom is a fracture that's slightly more distal, so it enters the distal radial ulnar joint, and again, it either does or doesn't involve the ulnar styloid, and it either does or doesn't, it either is or isn't intra-articular. So that classification is quite nice. I'm not sure how much it affects what you're going to do, other than the fact that it's intra-articular. We need to have a high index for referring the patient for fixation. Okay, next one. Okay, analgesia. So the patient presents to you, they've got a dinner fork deformity. It's either going to be a high or low energy injury. If it's a high energy injury, patently the ATLS, ABC, trying to work out what other injuries maybe are more critical to manage first. But having done all of that, we get to the point where we now need to manage this fracture. We've got an X-ray, it's displaced, we want to manipulate it, and how we're going to provide analgesia. So hematoma block is our go-to way of doing it. Now remember, you are putting a needle into a fracture, so technically you're converting it to an open fracture. So knowing that, gloves, sterile technique, obviously pay attention to detail. Then having done that, what are you going to use? Well, you could either use lignocaine or marcaine, and lignocaine with or without adrenaline. With regards to the amount that you can use, one just doesn't have to, one mustn't go above the toxic dose. So I mean, you're not going to do that anyway, but it's 3 milligrams per kilogram lignocaine, 6 milligrams per kilogram lignocaine if you use adrenaline, and 2 milligrams per kilogram marcaine. So, you know, Joyce is my wife, but she's an anesthetist, and she's, I know, given a talk on this before, so she would prefer to use marcaine, bupivacaine, and her rationale is because the duration of analgesia is longer. I probably would use lignocaine because I'm more scared of, if it goes intravenous, I know how to manage it a bit more easily than I would if it was bupivacaine. So the hematoma block is good, easy, reliable, works well. I encourage you to do it. It's certainly not beyond your ability to be able to do that. And there's just a picture of somebody giving the injection. If you want to use conscious sedation, that's also cool. That's commonly used as well. But hematoma blocks work well. Okay, next one.
And then just quickly, in your guys' department at Frere, what would you say would be the standard of practice for analgesia for Colles fractures? Do most people use hematoma blocks?
Yes.
Okay, because I can say that it's something I haven't seen done very much. I know the guys at Madwaleni didn't do them at all.
Okay.
So it's definitely not something that's practiced commonly in some contexts. Yeah, I had a few goes at them and found them to be a little bit trickier than the YouTube videos that I watched made out. Yeah, I don't know. Yeah,
Okay.
I guess.
So an alternative, if you do one and it's not, and you haven't got a happy situation, then you can use sedation as well, or just use sedation, whatever you're comfortable with. But I think it is a safe technique, and I think it's one that works. We're using them for our shoulder dislocations. We're using them for quite a few things now. So and the guys report that they've got pretty good results with using it.
Okay, cool.
Okay, so reduction. Now the technique, it would be nice to be able to demonstrate that. Maybe Dylan, you could organize a little video on that. But effectively, what one needs to do is reverse the deformity, and there's 6 components to a Colles fracture, and you need to reduce all of those. So the first is that a Colles fracture is impacted. Second is that it's dorsally displaced. The third, that there's dorsal tilt. There's radial displacement, there's radial tilt, and it's a supination injury. Okay, so those are the 6 components of a Colles fracture. And to be able to reduce it, the first thing you must do is you must disimpact it. And that's where the traction is forced, disimpacted. And having done the disimpaction, you then now need to reduce the tilt and the displacement in both the coronal and the AP plane. Okay, so I think getting the reduction is fairly easy. I would suggest that it's probably going to be a more than one person technique. Somebody's giving you counter traction and you're giving traction, and then manipulation. And once you've got it reduced, then obviously you need to put a plaster on, and it's quite nice to have somebody holding the position of reduction while you put the plaster on. Okay, so reduction technique, all I've got to show you is that you reverse the deformity, those 6 components, start with disimpaction, and then counter pressure for the displacement and the tilt.
Shall we just maybe pause for questions?
Okay.
Would anyone like to ask a question? I just saw someone raise their hand. I don't know if you were wanting to say something. Okay. all right, maybe not, but
Okay.
just the reduction technique there. I'm not sure if it's going to work, but looking at the next slide, you can see that that's one of the doctors at Madwaleni busy holding the reduction in place. And that's more or less the position of 3-point pressure, hey, of correcting the dorsal tilt. Getting
Okay. Yeah.
Why don't you critique that position there? I know that he's just holding it, but in terms of what's going on there, what do you think?
I'd probably say you can be the best manipulator of fractures in the world, but if you can't hold the reduction, you've basically wasted your time. So it's one thing to do the reduction, and the reduction is what we've spoken about on the previous slide, but you've got to maintain the reduction. That it might be impossible to maintain it. The arm's too big and too swollen. There's comminution, and you just haven't got anything to actually hold against. So I think. But having said that, 3-point pressure, yes. So 3-point pressure basically is putting pressure on 3 points each away from each other. So the ways to do it badly would be to put the palms of your hand at the same level and just squeeze the forearm. That's not going to do anything. They have to be at different levels. Okay, but the hand that's pushing the distal to the fracture must be distal to the fracture, not distal to the wrist. Because if the distal hand is beyond the wrist joint, all you're going to do is put the wrist into a hyperflexed position, which is very, very uncomfortable. So 3-point pressure, and the 3 points are all on the radius. Okay, so that would be the point, I think. And then you want the wrist to be palmar flexed, and you want there to be an ulnar tilt, because you're reversing the deformity that was there before. I think I'm not quite sure who's doing that manipulation.
With Johan, Gansevoort.
Hansi, okay, all right. So he's done lots of it. I think that looks good, Joyce. Dylan, is the other lady? What is she doing?
She's just putting on a plaster. I think she's just starting with a plaster. So they've obviously just reduced it. I was looking for some pictures of reductions happening, and I couldn't really find anything else. But I think your point about the position of the 3-point pressure on the distal portion of the fracture is very valid. I find when you send patients for the control X-ray, you can see where your molding was on the pop, where your finger was, and often I find that my thumbs were too distal, and they were actually sitting like distal to the radius on the actual carpus, as opposed to on the distal fragment of the fracture.
Yeah, that fragment can be quite small, so it's not necessarily simple, but that's what you need to aim to do. You mustn't hyperflex the wrist, because that plaster is going to be on for a while, and your patient will complain, won't be happy. Okay, so what I would like with putting the plaster on is, if I'm the operator, I would like to be the person holding the reduction, and that I'd like my assistant to put the plaster on, because I think the most important person in this is the reduction that you've got. So when the plaster's on, you can mold it. Okay, so what I would do then is I would hold the elbow, and I would hold the middle finger, and I would put traction on. Okay, or traction and counter traction. So I'm holding the middle finger because it's away from where the plaster is going to be, and I'm holding above where the plaster is going to end. In other words, it's basically the elbow. So I've got one hand supporting the elbow, and the other hand that's basically pulling on the middle finger. Okay, so I'm holding my reduction like that, and then somebody else is putting the plaster on. Now, whether it's a slab or whether it's a full plaster, I think you must make a call. But whatever you put on, it needs to be well padded. See, it's the 3-point pressure that's going to hold your reduction, as opposed to the amount of padding that you've got on. So if you're good at applying 3-point pressure, then you can hold the reduction if the fracture is conducive to it. Okay, so I hope I've explained myself so that people understand what I'm saying. But if you're concerned it's very swollen, then maybe putting a slab on is a good idea, like a sugar tongue type of slab. All slabs, if you put a slab on, your slab must be 3/4 circumferential. It's not just a thin little piece of plaster on top. It must be broad. Okay, so I think that's critical, because then it has more than one plane of functionality. Otherwise, it's guaranteed to break. So all slabs must be broad. With your plaster, if you put a full plaster on, the distal extent of your plaster should not extend beyond the proximal palmar crease. If you look at your own hand and you look at your palmar creases, your plaster shouldn't extend beyond that, because if it extends beyond that, then the other thing that you want to do, you can't, and that's to get the fingers to move, because your plaster will then be a block to flexion at the metacarpophalangeal joint. So don't extend the plaster beyond the proximal palmar crease. And then proximally, you need to be sure that you can flex the elbow without the plaster cutting in to the front of the elbow. Those are just a few practical markers.
Cool.
Okay, if that's good, should we move on to the next slide?
Yeah, and you were saying there you would opt for a full cast as opposed to a slab.
I think if it was very swollen and it was a high energy injury, I think I'd probably put a slab on, because most high energy injuries are going to end up being operated on, and one really wants to stabilize and give analgesia. So I don't mind putting a slab on. In England, they use sugar tongue slabs for almost all of their Colles fractures, and what they would do when the patient comes back is they complete the plaster. So it's put on, so it's 3/4 circumferential. It's holding the reduction, but it's not complete. And then what they would do, the patient would come back for their fracture clinic appointment in 2 or 3 days' time, and the swelling's down a little bit, and then they would just complete it. They wouldn't take it off and put a plaster on. They just complete the plaster. So
what is a sugar tongue plaster?
I didn't say that again, did I?
What is a sugar tongue plaster?
A sugar tongue is basically a longitudinal slab that goes along the forearm dorsally, around the elbow, and then back along the forearm volarly.
Okay, cool. Maybe we can post a photo of it on the group afterwards.
So sugar tongue, ice tongue, something that you pick up. You imagine something that's a piece of metal that you squeeze to pick something, a piece of sugar cube up with.
Okay, all right. Okay, I think maybe just
but in practice, most often we would use a full plaster, but just make sure it's well padded, that it doesn't extend too distal or too proximal. That would be the way to go.
Cool. Yeah, and then just like sometimes the guys in rural, you'll find that you'll be limited in terms of what sizes of plaster of Paris you've got access to. So I know at Madoleni we would have times where we would be out of stock of the nice wide 20 mil material, or maybe like the 20 mil material just wasn't setting nicely. And so if you've only got narrower stuff, then rather opt for a full cast instead of a thin little slab.
Yeah. I mean, I think that is a problem. Obviously lack of materials. But if you didn't have 200 millimeter plaster slabs, then you can always make them up just by overlapping different slabs. But it just takes a bit more time. You can, but I mean, most of the time we would use a complete plaster.
Okay. Cool.
Okay. So things to look for on your post-reduction X-ray. Okay, so we're looking at the inclination of the radius, and if you look at the picture there on the left, the inclination, if you draw a line along the long axis of the radius, and if you draw a line along the articular surface of the radius, you can work out that angle of 22 to 23 degrees, which is what we call radial inclination. So that is important. Then the other thing that's important is radial height or radial shortening, and you can see if you measure from the tip of the radial styloid to where the ulna abuts against the radius, that height should be around 13 millimeters, and that's important. And then volar tilt, that's a lateral X-ray, and the distal radius normally tilts volarly by 11 degrees. So that's normal. Okay, so what's acceptable? So inclination acceptable if the change is within 5 degrees of normal. The radial height within 5 millimeters and they can accept 5 millimeters of shortening. Volar tilt, basically, we would accept anything up to 5 degrees of dorsal tilt, dorsal angulation. Okay, so that would be the range that we would. So if you've done your post manipulation X-ray, you'll get an X-ray that looks more normal than the pre one, hopefully, and then you need to try and have a look at these angles and distances to see whether it's acceptable or not. And then if it is intra-articular, then we don't want a step in the articular surface any more than 2 millimeters. So those would be the criteria for me to say whether that's what I accept or not accept. Okay, so I'm not saying remember all of those things, but when you do when you circulate your talk drill, and if that is there, then that's something that they can remind doctors in rural can remind themselves of, because it is quite helpful to know whether is what I've got okay or not.
Yeah.
But sometimes if you want to refer and get advice, you can send the X-rays and somebody else can do it for you. But those are the criteria we use.
Okay. Cool. Awesome.
Okay. So with regards to definitive treatment, then, okay, we either do a manipulation and anesthesia with a definitive cast or a splint, or we look at something that's beyond that, and that's either closed reduction and percutaneous pinning, plating, whether it be on the volar or the dorsal approach, or the use of an external fixation. So I won't harp on the last three, because in the rural situation, you're unlikely to be doing that. If you look at the over 65s, and having just turned 65, I guess that includes me. But if you look at them, there's a meta-analysis that's basically had a look, and it says that in over 65, there really isn't any difference in functional outcome if you do an open reduction internal fixation versus closed manipulation. So if you're in the rural area and you've got an elderly patient, then it would be more acceptable from a functional outcome point of view to not send the patient for surgery. Okay, and if you're going to treat this way, then you want 6 weeks of at least 6 weeks of immobilization. So be in the cast or splint for 6 weeks. So that would be your option. And if you go the route of definitive cast, then you do need, if it's an elderly patient, I'd probably accept what they've got anyway. If it's a younger patient or a high energy patient, you've got a good reduction. Just remember to see the patient regularly and repeat the X-ray to make sure that you've maintained the reduction. Okay, so swelling comes down, plasters become loose, and you can lose your reduction. So the sooner you find that out, the more easy it is to do something about it. You don't want to put the plaster on saying that's cool, see the patient in 6 or 8 weeks time to take the plaster off, and then realize that they've malunited. It's too late to do anything about it then. So I think fairly frequent follow-up with X-rays is important. Okay. And just one comment with regards to the second option, closed reduction and percutaneous pinning. There's a lot of, in first world and private sector, there's a lot of talk, when locked plating came out. A locked plate basically gave you better grip on osteoporotic bone. So it was the bee's knees that everybody should have a locked plate. So there are people who say, well, if it's broken, then we're going to put a locked plate on it regardless. And that, in the private sector, that certainly seems to be a feeling. But there's material from Scotland in a high output trauma unit that's now got 5 years of follow-up that says closed reduction and percutaneous pinning, the functional outcomes are just as good as locked plating. So I don't think we have to go to all these expensive things in order to get a good functional outcome. Okay, all right. So that's sort of off the point a little, but I think it is important.
Yeah, that's cool. Nice. Cool. So maybe before we go on to ankles, I'm just gonna say if anyone has a question, then we can answer it now. People are very, very quiet today.
Hello, can you hear me?
Yes. I can.
All right, okay. Yeah, that's Dr. Nadim at Queenstown Frontier Hospital. Right, I just have a question about delay presentation. We found ourselves seeing patients who comes to us from rural places, maybe 2 or 3 weeks after they had their manipulation done primarily. Then maybe they were reviewed after 2 weeks, or for transport issues, as you know, in the rural areas with ambulances, and they only present to us 2 or 3 weeks later. And then it became almost impossible to do the manipulation. And you see the initial x-rays and you think like it could be something very, very easy to do at first. And now they present to you 2 or 3 weeks later after that. Will you still advise that we can try manipulation at that stage, or we can just keep it for an ORIF and then percutaneous wire later on? That I'm talking about the patient that comes 2 or 3 weeks later on after they've failed the manipulation.
Okay, so I think it's more an observation than a question. I absolutely understand what you're saying, working in a referral hospital. I'm not sure how big your clinics are. You know, there was a time when we were seeing 200, 250 patients in a day in our clinic, and we made a concerted effort to try and cut back on our numbers coming to us. And I'm sure that's partly contributed to the fact that maybe we're not seeing some patients that we wish that we had seen when they come a bit later on. It's just a difficult situation, you know. I think if I see someone with this injury and a 2-week follow-up X-ray, they've displaced, I think there's still good time in order to actually go and do something. But if the patient only presents to me, as you said, 6 weeks or 8 weeks later, it's a different ball game. And you know, the horse is bolted. Now you're doing reconstruction as opposed to reduction. And so my plea would be, and I think you're saying the same thing, is if you do your post-op manipulation X-ray, you look at the criteria that I've mentioned, and it's not great, then refer early. Or if your initial X-ray shows that the patient has got a comminuted fracture or has got an intra-articular extension, then probably refer that patient anyway, just to give us the chance to do something whilst we can. Would that be what you're really trying to say?
Yeah, that's what I'm trying to say, that I just want to get an advice on, let's say, 2-3 weeks. Can I still try manipulation? Okay, I've tried for some patients.
Yeah.
And okay, not a great outcome anyway.
Yeah.
And very difficult, because then you don't have an hematoma block, then you have to go for a wrist block, basically, or you do a sedation. So I've tried for a few patients, it did work,
yes.
but for most of them, I end up either referring or let them go into a malunion, or then do an ORIF, a proper ORIF, then you do your percutaneous pinning.
So, and I think it's a little bit not quite what the rural doctors are needing to hear, but basically, if the patient's presenting to you 2 weeks or beyond that, then your manipulation is going to be really difficult. You need much better analgesia. So either do a Beers block, brachio block, or even a GA. I don't think sedation is going to help you. And then you need to make up your mind: is it reducible or not? And if it's not, I wouldn't go and try and prove to the patient that I'm stronger than the fracture is. I think if it's not reducing easily, then just accept the fact that you have to operate, but then you must choose your timing as to when's appropriate.
Okay. Well, thank you.
Okay.
Cool. Thanks, Dr. Matimba. Are there any other questions before we move on to ankles? Okay, cool.
Dylan, I've got one thing that I didn't say that wasn't in my talk, but Koshi said to me maybe I should mention this. So
just hold on a second there. I think there was someone that was about to ask a question. I don't know. Are you still there?
Yes, I'm still here.
Cool, go for it.
Speaking to Dr. Mohammed, I'm currently working quite deep rural, and we've been without x-rays for over a week now. We've tried to shut down our casualty, but unfortunately, without a clinical manager and our CEO refusing to actually do anything, it's proven quite difficult to do so. We have escalated our issues, our management issues, but currently, without the x-ray and with alcohol being involved again, and with us seeing a lot of these fractures, those that are closed fractures, Unfortunately, referral hospitals are not taking our patients due to these management issues. Do you suggest, Doc, that we still try these manipulations without x-rays and then review these patients in 2 weeks when we would hopefully have x-rays back? Or do you advise against it?
Okay,
I know
so
that's a tricky question.
no, I mean, thank you for the question, because we're obviously working in compromised environment, and you know, lack of X-ray availability is a reason for patient referral to our hospital from certain places quite often, actually. So it's not unique to you. But the question is, you know, rather than trying to help you with your with solving your problem, the question is, would I suggest that you manipulate it?
Without an X-ray, yes.
Without, okay, if you've got a classic, you know, if you've got an elderly patient who's had a simple fall and they've got a classic dinner fork deformity, then I think you're not going to do any harm if you do longitudinal traction. So,
Okay.
you know, if you're not quite sure what the injury is, maybe use some other form of analgesia rather than a hematoma block. So that might be something to do, but there's almost, you know, if the patient's neurovascularly intact, there's almost never a reason why you can't just put traction on and give it a push and see it happens. You almost regardless what it is, you're going to improve the situation. But patently, there's a whole spectrum of pathology out there, from you know, perilunate dislocations to Barton's to Smith fractures. I mean, there's quite a few different types of injury. But regardless of those, I think longitudinal traction, just giving it a push, I don't think you're going to do the patient any harm. You might not reduce what's, you know, if it's not what you think it is, but I think it's reasonable to do that. But my other advice to you is just to document what your situation is in every single patient that you actually do it to. Because if there's a negative outcome, you don't want it to be thrown back at you that you did something naughty or bad when actually you couldn't do what you should have done because you just couldn't.
Thank you so much for that clarification, Doc.
Sure. Okay. Dylan, the thing that I wanted to say that I didn't is that chronic regional pain syndrome is a problem with distal radius fractures. And there is literature coming out that suggests that fairly high dose vitamin C augmentation peri-fracture is helpful. So the use of vitamin C in wrist fractures is something that's in the literature now, and it's something that people are starting to use more and more.
Interesting. Dose and duration?
I don't know. So it's not something that I've ever used, but it's in the literature, and I can't tell you whether it's a gram a day but it's sort of in that ilk. So probably I think tablets, vitamin C tablets, I think are 500 milligrams.
Yeah.
I think so, maybe 1 or 2 tablets a day.
Okay, sure, that's interesting.
But you'd have to Google that just to sort of see. But it is something that's there, and you know, chronic regional pain syndrome can be a problem with distal radius fractures. So it's something that you could use. It's not expensive. Yeah.
Cool. Thanks, Dr. Mohammed.
Hi, sorry, can I ask?
Yeah.
Sorry, hi. I just want to ask if he's going to expand more on how to do the hematoma block.
I think that it's a little bit difficult to talk in too much detail without being able to demonstrate it. But what I'm going to do is I'm going to see if I can find a good video on it. And if not, then maybe Norrie, myself, and Joyce can put a little video together for you guys, and then we can post it on the forum on the group. So we'll do that. And then we can actually like film landmarks, and I think it'll be a bit easier than talking about it more in this forum. Do you agree, Norrie?
Yeah, I do. But we're not fobbing you off. We certainly can put something out there for you. That's a resource for you. Yeah.
Thank you.
Okay.
Cool. Any other questions? Cool. All right. So I think it's quarter to 6. Quarter to 6. So sorry, can you just mute your microphone there? Let's see how far we go. 15 minutes. Sorry, can someone's got their mic on? I don't know who it is. Can you just mute yourself, please? Okay.
Yeah.
All right. Thank
All
you.
right. So, okay, are we good, Dill?
Yeah, go for it.
Okay, so what we're going to do is we're going to have a look at ankle fractures. And specifically, you wanted me to the Weber classification and go that way. I think I just put this picture up. It's actually from Lager Hansen classification. I think don't worry about the letters at the top. But basically, as you can see, there's a spectrum of pathology. This is all different patients with ankle fractures, and so it's not that easy necessarily to just look at the Weber classification and say, this is how we do it, because it's multifactorial. Anyway, the ankle fractures, another common injury. So let's move on and have a look. So this is pictorially the Dennis Weber classification, and they're just described as A, B, and C, and they're all related to the level of the fracture relative to in the fibula. So it's either going to be infrasyndesmotic or transsyndesmotic or suprasyndesmotic. If you look at and then, all right, that's fine. So the A, B, and C, and the B's, the transsyndesmotic, either going to be, they either isn't an associated medial malleolar fracture, or there is one, or there's one as well as a posterior malleolar fracture. So the B's would go into B1, B2, and B3, dependent on associated fractures. Medial malleolar, no medial malleolar fractures B1, a medial malleolar fracture B2, and a posterior malleolar fracture associated would be a B3. Okay, and then the C's, the suprasyndesmotic are C1s and C2s. So C1 is low, as you can see drawn there, and C2 can be high. It can be anything up as far as the fibular neck. So when we do X-rays and investigation clinically, that has a bearing, because you might not see it just on an ankle fracture. But let me say then that if you look at the Weber A's, I mean, the way it's been drawn isn't quite right. So effectively, if a fracture is pushed off, it'll be an oblique fracture or a spiral fracture. There's a rotation element. If a bone is pulled off, it'll be a transverse fracture. So with the A's, what tends to happen, there's a distal fibular fracture, which is a transverse fracture, and there's an oblique shear fracture of the medial side, which is quite a big chunk of bone. That's the Weber A. The Weber B and C, there would be a transverse fracture of the medial malleolus because it's been pulled off, and an oblique or a spiral fracture of the fibula because it's been sheared or rotated. Okay, so basically A, B, and C is infrasyndesmotic, syndesmotic, and suprasyndesmotic, and the B's 1, 2, and 3, and the C's 1 and 2. Okay, good. So that's what is the Weber classification. So, there was a question with regards to compromise and difficulties with wrist fractures, and patently these are common injuries. I think there are resource constraints that we're all affected by, and because an ankle can be put in plaster and hidden away, it's very tempting to go ahead and do that and spend your theatre time putting nails and femurs and things like that. There's only a certain amount of theatre capacity available, and if that capacity is fully utilized by doing those types of things, there just isn't time or space to be able to fix ankle fractures. So when I bring in interns or young doctors into our department, and we speak about, we're going to have all these meetings every day, and in the meetings we're going to tell you how things should be done, but you'll see that we don't always practice what we preach, and that's not necessarily because we're bad doctors. It's more because we just can't, because the lists of patients waiting for theatre are just too long. So So there is a large degree of compromise, and because ankle fracture is a fracture that can be hidden in a plaster, many patients get treated with plasters that ideally should not be. They should be operated on. So there's resource constraints with regards to theatre time. There's resource constraints, as you've heard already, with regards to materials, and that's plaster of Paris crutches. Then there's compliance problems. You know, so you say, well, I'm going to treat this patient in plaster of Paris. But technically, then the patient needs to be compliant with non-weight bearing. And I can tell you, at least 90% of my patients walk on their plasters, if not all of them. So that doesn't work either. You know, you can say, well, then I'm going to put an above knee plaster on, and I'm going to flex the knee to 90 degrees. They devise ways of walking on it anyway. I tell them I'm going to put drawing pins in the sole of the plaster, so that if they walk on it, it's going to go into their skin. I've never done it, but it also doesn't work. So poor compliance is a problem, and some patients are just so heavy or so frail that they can't non-weight bear. So problems. But with regards to resource constraints, just like I told the lady that she should make good notes, you do need to make good notes. So if you are constrained with what you can do, because there's no bed, because there's no theatre time, you must write it in the notes, because it'll come back and haunt you otherwise. Okay, we need to know a little bit about anatomy and radiology, and I've got a few slides about that. We need to talk a little bit about the timing of treatment, and skin tenting, edema, blisters, indications for surgery. You know, what do you do if the fracture is an open fracture versus a closed fracture? I need to say a few words about diabetes and ankle fractures, and then we'll talk about referral. Okay, so let's carry on. We might not finish, but we'll do what we can. So patently, there is a spectrum of pathology, and it includes all of the things listed there. So you might have an isolated medial or lateral malleolus. It may or may not be displaced. But quite a few of these injuries are stable and lend themselves to non-operative treatment. But your bimalleolar fracture is most often requiring open reduction internal fixation with surgery. Okay, so that's just the way it is, unfortunately. And if you want a reliably good result, then you need to operate on a lot of ankles. But we put a lot of ankles in plaster, which we generate problems from that. Okay, but that's just the way it is. But I mean, I'm here to tell you what should be done. And if you've got an unstable fracture, if you've got a bimalleolar fracture where there's any form of displacement, you need to refer that patient for surgery. Whether the surgery is done or not, that depends on our constraints. But there you go. That's what you've got to do. Okay. Next slide. Okay. So basically, there are certain X-rays that are useful to get if you've got access to X-rays. So an AP and a lateral. It's obvious. Then a mortise view. A mortise view basically is a 20-degree internally rotated film, and it's really saying that the fibula is lying posterior relative to the tibia. So if you internally rotate the leg, then you can bring the fibula into the transverse plane with the tibia. So what you see with the mortise view, you can see the gap is the same medially, superiorly, and laterally. Okay, so there's an AP view, there's a lateral view, there's a mortise view. The two pictures below demonstrate a way of trying to get an external rotation stress view. I think that the reason why that's there is to tell you that sometimes it's quite difficult to know if there's a medial injury or not. And an external rotation stress view is the easiest and the best way to determine if there's a medial injury. Okay, so the presence of bruising or tenderness medially isn't as helpful as doing this external rotation stress view. And it can either be done, as you can see on the X-ray, with somebody externally rotating the foot, and the way it's done with the clinical photograph is a gravity stress test. So the patient's lying on his side, and gravity is doing the same thing as what's happening on the X-ray on the right. Okay, and then the full-length tib-fib X-ray is really just to diagnose or exclude the massive nerve or the high C2 fracture. So those would be the films that would be helpful to you. Okay, next one. Okay, some x-rays, quite nice to know. So when we talk about the talocrural angle, we're really talking about the fibular length. Okay, so the line drawing on the left shows a drawing a line at right angles to the long axis of the tibia, with angle at right angles to that. And then the other line is drawing the tip of the medial and the lateral malleolus. And it's the angle that subtends. And it's normally 82, 81 degrees. That's normal. If the fibula shortens, you can see that angle is going to get bigger. Okay, so relative to 81 degrees, what is the patient? So you can, it's a fairly easy thing to measure to determine whether there's any fibula shortening or not. Okay, so that's the talocrural angle. Next picture. Okay, and then there's what we call the clear space between the tibia and the fibula, the x-ray on the left at the top. If you measure a centimeter from the joint line and you measure the distance between the tibia and the fibula, that should be less than 5 millimeters on both mortise and AP view. So that's a reference that you can look at. Then if you look at the x-ray at the bottom, we're looking at the medial clear space. Okay, so if that space is increased, that means that there's talar shift. And what I want you to know is that 1 millimeter of talar shift represents 42% decrease in tibio-talar contact area. So it's quite subtle, but it's gross. You know, so I mean, it's a subtle change, 1 millimeter, but there's a dramatic amount of abnormal biomechanics in the joint if you don't get it just right. So it is important to have it reduced. And then the picture at the top right is just the tib-fib overlap. And that's what I'm trying to demonstrate to you, that the fibula is lying a little bit posterior, which is why there's overlap. So on an AP view, 6 millimeters, and on a mortise view, 1 millimeter would be that you'd expect to see. So if those distances are exceeded, then there's either talar shift or there's a syndesmotic injury. Okay, so those are just some pictures for yardstick, and a few more on the next slide.
I just wanted to say, what is the link between talar shift and risk of osteoarthritis again?
Okay, so if you've got persistent talar shift, then you're over a period of time, you're almost guaranteed to your altered biomechanics, you're almost guaranteed to get arthritis. Okay, so whether that arthritis is symptomatic or not is another story. There are some people who have got degenerative changes in the joint because of malunions, and they say, but I don't want an operation, I'm fine, thank you. So I suppose it's partly functional demand. So if you've got a manual laborer, they're probably going to complain more than somebody who's elderly and doesn't walk around very much. But you want an anatomical reduction. Okay, so these are the criteria to determine whether you've got anatomical reduction or not. Okay, so I'm not sure. So these really are looking at posterior malleolar fractures. I won't spend too much attention on it, but quite often I think it's become much more significant to know and manage the posterior malleolus, because the ligaments between the tibia and the fibula are connected to that posterior malleolar fragment often, and so it is important from a function point of view to know that there is or isn't a posterior malleolar fracture. So the double contour sign, if you look at the x-ray on the left and the black arrow, you can see immediately there's a double contour that shouldn't be there. The Misty Mountain sign is the x-ray on the right, where there's a tiny white arrow. Okay, and then the spur sign is the red open arrow that you can see. Okay, so those all would indicate that there's a posterior malleolar component to it. Okay. Yeah, I'm just showing you that to try and just to make it interesting. I don't think you need to know that, but and there you go. Okay, next slide.
We've got into 6 o'clock here. So
Yes.
my audio is a bit echoey, but I think it's probably a good idea for us to stop there and not rush through the last bit.
Okay.
I think people's concentration levels are also going to dwindle at 6 o'clock after an hour.
Okay.
So I reckon, why don't we aim to just film the rest of the presentation and stitch it on to the rest, and then I will share this this video recording in the shared Google Drive, and then you guys can just log in and download it and just watch the last component of the presentation. Maybe should we just create a space for a couple of questions to end off? If anyone has any burning questions they'd like to ask before we close.
Got a question? Got a question?
Yeah.
Okay.
Okay, Dr. Madimba again, Frontier Hospital, Queenstown. Right, I saw the common X-rays that we receive from rural, even some of our doctors in the referral hospital. Still, I don't know if I would say we're still making the same mistake. Can we still apply, let's say, the rule of two? Like when the joining involved, or bone involved, we say we need to have 2 X-rays. We need to involve the joint below and the joint above the fracture. For instance, in these bimalleolar fractures, what I found, some of patients comes in with below knee POP, with X-rays that are basically focusing on the ankle and then the malleolus, just to find out if fracture has been missed. That's on the proximal fibula, for instance, and then that becomes a segmental fracture. So I've seen that quite a lot. And I just want to ask the question, should we, for the purpose of not missing those fractures, should we include it, like doing the X-rays on the ankle and the joint on the injured limb?
Kan al dit prinses.
Okay, I'll try and answer that. I think you know there's 2 things involved here. There's clinical examination and there's radiological investigation. So if there was any doubt in my mind as to whether there was a high Weber C component, then I would definitely X-ray the entire length of the tib fib to include the joint above. I don't have a problem with that, but I don't think that I would routinely X-ray the tib fib for every ankle fracture. So I would have to have an index of suspicion. So if I was sure that there was an ankle fracture and I did the ankle X-ray and there was nothing there, then I think clinically and radiologically one needs to exclude it by getting the tib fib fracture. So I wouldn't suggest you do a full length tibia. I mean, you know, your rule of 2 is 2 views, 2 joints. I mean that's a good rule for a shaft fracture, but for an ankle fracture that has got no tenderness anywhere around the knee, I would probably not request for that to be done. But if there was any clinical index of suspicion, I would want it. So I'm sort of semi saying yes and semi saying just use your clinical expertise to determine whether you do it or not.
Cool. Awesome.
Okay. All right, Dylan. Are we done?
Yeah. Thank you so much, Norrie, and all of you for joining. Yeah, we're gonna just record the rest of the presentation, add it on, and then pop it in the shared Google Drive folder. And yeah, thank you so much for your time, Norrie. That was really, really useful. And yeah, if you guys do have any other questions that you didn't get to ask, feel free to message me, and then I can forward it on to Norrie, and we can arrange for him to respond to your questions. Cool. Thanks so much, guys.
Cheers, Dylan. Thanks. Bye-bye, everybody.
Okay.
Good luck.
Thanks, Dylan. Just remember to export the chat.
Yeah, I'll do that now. Thank you.
Cool. Thank you very much. And yeah, people, please sign in if you haven't yet. Just let us know who you are, so we have a bit of an idea who attended. It helps us to tailor make these sessions. Well, it helps Dylan to tailor make these sessions. Thanks.
Yeah.